Thank you very much, Dilip, and welcome to you, ladies and gentlemen. This is such a beautiful part of the world. It's certainly a pleasure to be able to speak to you, and clearly the attractions of a cloudy Côte d'Azur morning are not quite as great as they would have been if it was nice and sunny, but we'll try and make it interesting. Thank you first to the organizers for asking me to come to this first ERAS Society meeting and talk about translational science, really. Yes, I'm a basic scientist, but what I do is essentially clinical research with various collaborators, and in fact 2 of them are sitting there because Franco and I have at least 2 joint publications, one in the American Journal of Physiology, which isn't bad for an anesthetist to be in a journal like that, and Dilip and I have got many publications, as you'll see as we go through this presentation. So I'm going to cover the issue of muscle physiology as it relates to the sort of clinical conditions that you're interested in as far as ERAS is concerned. So a little bit of reminding you about the relationship between muscle structure and function, something about muscle metabolism, and then the more applied aspects in which would be of relevance, one hopes, as far as your own clinical areas and research areas are concerned. And then some potential things that may be worth thinking about for the future. I was very honored to be able to listen to Henry Kellett yesterday. I think he's been a challenging voice for many years. Before Dilip came to Nottingham, Simon Allison was one of my main clinical collaborators, and Henrik and Simon did a great deal as far as nutrition issues and undernutrition in older individuals. And so to hear Henrik talk about using muscle contraction movement as being key features of your fast-track surgery and your enhanced recovery is quite interesting and reassuring to a simple physiologist like myself. But there may be other aspects of muscle that could be incorporated as well to make it even more interesting as far as the future is concerned. So I'll keep it fairly simple. I'm not a muscle biochemist, you'll be glad to hear. So my take on muscle is fairly straightforward. There are 2 major fiber types in skeletal muscle you need to be concerned about, type 1 and type 2. There is some overlap between them, and the 2A fibers, and 2X, in fact, in some circumstances, some people argue anyway, are a mixture of these 2 basic aspects. So type 1 fibers are the slow contracting oxidative fibers that keep you going during endurance events. They're fatigue resistant. They can use fatty acids as well as glucose as a fuel, and they are the more insulin sensitive fibers. The type 2 are the fast contracting anaerobic fibers with some oxidative capacity in some circumstances. They're easily fatigued. They use phosphocreatine first, then glycogen and glucose if they're used for a long enough period of time. But these really are the sprinting type fibers, the ones that allow you to have a rapid response, whereas sustained movement depends upon these type 1 fibers. The principal role of muscle, of course, is contraction for physical activity and exercise, but also, of course, for maintaining life. It was interesting to see the anesthetist's view on who was the most important person as far as the patient is concerned, because one of the anesthetist's roles is, of course, to make sure that you breathe properly, and in order to breathe properly voluntarily, you need skeletal muscle to be working appropriately. Muscle glycogen, as I'm sure you're aware, the carbohydrate store in muscle, provides a substantial fuel store, principally for use within the muscle, but in fact, especially in those fast twitch fibers, if you stimulate glycogen breakdown to be at a faster rate than the oxidative metabolism will go on, then you generate lactate that can be released into the blood. You clinically probably regard lactate as a bad thing being released into the blood because of its effects on acid-base balance. But actually, metabolically, it's quite useful because it can go to the liver and be converted back into glucose and then be used around the body as glucose. So it can lactate, as long as the liver's working properly and you've got the right endocrine environment, can be used to increase blood glucose concentration. The one thing that is important as far as fuel in muscle goes, and also the thing that's very confusing, is the fat store in muscle. So there is an intracellular store of triglyceride within skeletal muscle. It increases as your body mass index increases, so our obese patients have got a lot of intramuscular fat. And they don't use it very well, if at all, and it contributes to their insulin resistance and probably to the generation of inflammatory cytokines by skeletal muscle. The confusion is that if you take a lean endurance athlete and look at their muscle, then they will have a high muscle fat store as well. So you have your obese patients who've got a lot of muscle triglyceride, but also an endurance-trained individual will have a lot of muscle triglyceride as well. The difference is that the endurance-trained individual will turn over that triglyceride quite regularly because they use it during prolonged exercise, and then it gets resynthesized and restored over the next few days. And in fact, the fuel store in skeletal muscle of an endurance athlete, represented by the triglyceride, is more in terms of calories than the fuel store in the glycogen in the muscle. So if somebody is stupid enough to run a marathon, then just over half of the energy delivery from the energy used by the muscle during contraction in a marathon comes from the intramuscular triglyceride, and just under a half from the intramuscular glycogen and from blood glucose as well. So muscle triglyceride is a good thing as long as you're making the muscles work regularly. If you're a sedentary, obese individual, then muscle triglyceride is a bad thing because it contributes to your insulin resistance. So what about muscle metabolism? Well, high-intensity exercise, especially in those fast-twitch fibers, uses phosphocreatine. It uses glycogen glucose. It needs carnitine in order to buffer excess production of acetyl-CoA. And it can be enhanced by creatine and also by carnitine supplementation. I'll show you the creatine in a minute, and I'll show you the carnitine at the end. Endurance exercise, as I've said, uses fatty acids at the low to moderate intensities. As the intensity then increases, you need more and more carbohydrate. But one of the effects of physical training is that if you are a well-trained individual, you can use fat as a fuel to a higher intensity of your maximum capacity. So training doesn't just allow you to do more exercise, it allows you to use more fat during the exercise that you're doing. One of the consequences of that is that you improve insulin sensitivity with physical training. So the extent to which the clinical situations that you're concerned with, which certainly surgical procedures, even these fast-track ones, have the potential for making people insulin resistant. If you have the opportunity to optimize physical capacity, muscle function beforehand, then the likelihood is you'll have better insulin sensitivity before these procedures. And one postulates, but it hasn't actually been studied properly yet, that going into a procedure with a good insulin sensitivity will help maintain adequate insulin sensitivity during and after the procedure. But that's hypothetical that needs investigating at a later date. This is one of the early exploits we had into trying to enhance the ability of muscle to utilize some of these fuel stores, and this is creatine. If you looked in the literature prior to 1990, then the absolute dogmatic opinion was you could not do anything to alter creatine levels in muscle. It was partly synthesized from the liver, partly in the diet, and muscle took it up to a certain level. A chap called Roger Harris didn't believe this, and Eric Hultman in Sweden also found it rather difficult to believe it was so dogmatically the way it was. So they started to play with it and certainly found that creatine levels did vary across individuals. If you're vegetarian, you tend to have a bit less creatine in your muscle than if you're a meat eater. What we were interested in is that the creatine transporter, so the membrane transporter that moves creatine into skeletal muscle, is a sodium-linked transporter, as is the glucose transporter that insulin activates. And so we postulated that insulin may actually enhance creatine uptake. So the first experiment that we did was done by Alison Green, and we actually had subjects consuming creatine orally, or creatine with a carbohydrate bolus orally at the same time. So the carbohydrate would stimulate an insulin response, And these are muscle biopsy levels of phosphocreatine, creatine itself, and then total creatine, which is the sum of those two. And you can see that 5 days of taking creatine plus carbohydrate, so this is a 5-day period of supplementation, you end up with a substantial increase, a doubling of phosphocreatine and about a 30% to 40% increase in total creatine in skeletal muscle. We then used our glucose clamp technique in subsequent studies to show that if you gave creatine by nasogastric tube, because we could never actually get an adequately sterile and pure solution to infuse intravenously, so we used the GI tract to give nasogastric creatine while we gave intravenous insulin infusions and clamped the blood glucose. You find that when the insulin is at these levels, which are sort of high-ish postprandial insulin levels to really the top end of the insulin, these are infusion rates, but this would give you an insulin level to the maximum you'd likely see in a healthy individual. You get this massive increase in muscle creatine concentration, and this is an acute effect. This was 5 days here. This is 1 day or half a day. So insulin certainly mediates creatine uptake. This then has been used by quite a lot of people in the athletic and sporting fraternity to combine creatine with carbohydrate to maximize the availability of this fuel as far as muscle contraction, fast twitch muscle contraction is concerned. But there are certainly some clinical situations in which one might be interested in enhancing creatine as well. This slide just illustrates the effect of improved physical fitness, physical training, looking at the effect of exercise intensity against use of fuel. So at low intensity exercise down here, you use about half of the energy for ATP production in muscle is from fat and about a half from carbohydrate. If you're less fit, then you use more carbohydrate. As you go up the exercise intensity, so you end up eventually, if you're very unfit, requiring 100% carbohydrate use for your muscles to contract. But even at this maximum oxygen consumption here in a well-trained individual, you can still derive 10 to 20% of ATP synthesis from fat. So the effect of training is to make you use your body fat more during exercise, as well as to make you more insulin sensitive. So these are all things that need to be considered when you're thinking about your patients. This is the only biochemistry slide, so those of you who left medical school a long time ago, don't worry, there won't be a post-lecture examination on this stuff, and it's a physiologist's biochemistry, so it's very simple. Here we have glucose, so we have carbohydrate utilization on the left and fat utilization on the right. The situation here is that this is the mitochondria, so this is the cytoplasm of the cell. So glucose breaks down to pyruvate, and if you've got the capacity to do oxidative metabolism, that then crosses into the mitochondria and under the regulation of pyruvate dehydrogenase complex to acetyl-CoA to Krebs cycle here, and you get lots of ATP, and you eventually produce CO2. Fatty acids need to be linked to coenzyme A. Carnitine is involved. The fatty acid then gets into the mitochondrion, eventually produces acetyl-CoA, and also eventually produces CO2 and lots of ATP. The important thing here is carnitine. Carnitine is critical for fatty acid entry into the mitochondrion and for you to be able to use fat as an oxidative fuel. And the pyruvate dehydrogenase complex here is critical in regulating glucose oxidation. And if you get a lot of accumulation of fatty acids here, you get inhibition of this thing, and you get more fat oxidation and less carbohydrate. I'll come back to that later because of the role of carnitine there. So these fat-carbohydrate interactions, which are predominantly going on in skeletal muscle, but also in the heart and to some extent in the liver, are essentially the fundamental features of the Randall cycle, described by Sir Philip Randall back in the mid-late 1960s, and a fundamental part of the sorts of problems that go on in type 2 diabetes, where you have difficulties or failure to oxidize carbohydrate, partly at least because there's an excess of fatty acid around. So the insulin resistance after a high-fat diet, in obesity, in type 2 diabetes, with inactivity and immobilization, and with stress situations such as old-fashioned surgery, not this wonderful stuff you're now doing, these all will increase fat availability and lead, and probably some inflammatory cytokines in some situations, and lead to insulin resistance. And so that Randle cycle operating, switching, or interfering with the switch between fat and carbohydrate is an important aspect to be aware of as far as some of the clinical conditions that you may be associated with. Illustrations of the impact of high-fat diet and other things on insulin sensitivity are illustrated here. Now, this is a pretty heroic high-fat diet, although those of you who know about the United Kingdom will know that certain northern parts of the UK tend to have a fat intake that has never, ever seen a Mediterranean environment or anything else. But we had healthy volunteers consuming a high-fat diet with 75% of the energy from fat, or the average British diet of 35% from fat for 6 days. And then we did glucose clamps on them at the end of 6 days to measure glucose utilization, both oxidative and non-oxidative. And the control situation is here. These are reasonably insulin-sensitive people. Just over a half of the total glucose is used for glycogen synthesis, for non-oxidative disposal, just under a half for oxidation. With the high-fat diet, you can see the oxidation part diminishes, and actually the non-oxidative increases a bit. So this is a slightly peculiar situation. This is not complete insulin resistance, because actually the total glucose use is the same. In fact, even slightly elevated across here. But this is partly an artifact of the fact that this high-fat diet has caused glycogen depletion. And it's only 6 days, and so these people still have the capacity to respond to insulin, and we have just filled up their glycogen stores substantially. And so this is an artificial elevation in insulin sensitivity, but the important thing is that the high-fat diet diminishes their ability to oxidize glucose as a fuel. And these are the biochemical changes that go on. So this is baseline, these are the controls, and there's no change in this is pyruvate dehydrogenase complex, so that's the enzyme complex for the entry of carbohydrate into Krebs cycle, and you can see that insulin stimulates it. You can see here that there's no significant change in the baseline condition, that after a high-fat diet you suppress it, and insulin does not stimulate it. So this is the insulin resistance of carbohydrate oxidation that a high-fat diet will cause. We use such a high fat content there because we could only justify doing this for a relatively short period of time. It would be nicer to go to maybe 50% fat and do it for a month, but getting healthy volunteers to do that is not the easiest thing. I think Professor Lobo could probably persuade them, but I can't. So the other aspect of the sort of muscle physiology side of things that I wanted to cover before we then get on to the more modern ERAS components is undernutrition and starvation, because this is where we came into this with Simon Allison a couple of decades ago now, I hate to mention, but anyway. To start with, these are healthy volunteers with up to 72 hours of starvation. And this is an overnight fast, that's 36 hours of starvation and 72 hours. And these are the glucose infusion rates required in a glucose clamp to maintain a blood glucose concentration of 4. We chose that as an intermediate between an overnight, a 36 and a 72-hour fasted arterialized venous glucose concentration. So the concentration is the same, so there's no mass action difference here. The important thing is here, this is healthy insulin sensitivity after an overnight fast. It is diminished, and it's the oxidative component that is diminished after 36 hours. And at 72 hours of starvation, you don't oxidize glucose at all when you're hyperinsulinemic. So the adaptation to starvation has completely stopped glucose oxidation. And so the insulin resistance of starvation is a failure of insulin to stimulate glucose oxidation. And you can see here, this is forearm glucose uptake, and there is a progressive diminution in forearm glucose uptake as well over that time period. So starvation really does alter the influence of insulin on muscle, because this is essentially muscle glucose utilization, and the whole body setting as well. And this was Jonathan Weber's work when we were working with Simon Allison in the early 90s. That's been taken further, looking at the more metabolic aspects. And this now is not a glucose clamp, but it's a slightly shorter procedure, an insulin tolerance test, which I don't like very much because all you get is a global indication of insulin sensitivity. You can't measure glucose oxidation with it, but it gives you an indication of what might be going on. And this is the diminution in insulin sensitivity with the insulin tolerance test, proportionately about the same as we see with a clamp after 48 hours. And then when you refeed people, it starts to come back, but it doesn't recover immediately. And what we have here is, again, a diminution in this gatekeeper enzyme as far as the transition from glycolysis to Krebs cycle goes. We took a biopsy at 24 hours and again at 48 hours, and you can see there's this progressive fall, but most of it happens actually in the first 24 hours, and then it begins to recover during refeeding. And this is one of the enzymes which regulates PDC. So as this goes up, pyruvate dehydrogenase kinase, as it goes up, PDC activity goes down, and you can see here that this seems to be the gene and the protein which are responding to starvation by upregulating and in turn downregulating the PDC so that you don't get as much glucose oxidation in skeletal muscle. What this is doing from a teleological point of view, of course, is conserving the glucose for the parts of the body that require it in a much more critical fashion. And of course, that's predominantly the central nervous system, to some extent the erythrocytes and the renal medulla. So the glucose, the obligate glucose utilizers, certainly in the early stages of starvation. The other thing about undernutrition, and this is historical, but it's worth reminding people because it certainly links to the sorts of things Henrik Kellett was talking about yesterday, is that one of the consequences of undernutrition is that you do get a diminution in muscle function, and you get this reduction in muscle function well before you get any change in muscle mass. And then a reduction in muscle mass just makes it worse. And these are illustrations here of maximal force of the adductor pollicis. So you electrically stimulate the muscles of the thumb. And what you see is that in undernourished men and women, you have diminished maximal forces. But the important thing is the relative response. So this is percent of maximum, so that they're normalized to 100%. The relative contribution of low frequency, so these are the endurance type fibers, compared to high frequency. And so the effect of malnutrition is that you lose the high frequency fibers, or the response of the high frequency fibers more than the endurance fibers, so that there is a switch in the fiber types that are recruited during electrical stimulation. And 4 weeks of TPN in these patients produced a substantial improvement. I suspect this is one of the first papers that then triggered the sort of eventual interest in your ERAS carbohydrate supplements, which now have got all sorts of fancy things in them, but the critical thing I suspect in all of them is carbohydrate. And these were undernourished patients who were given a pre-operative infusion of a small amount of glucose and some potassium, because of course as glucose enters the cells, insulin will drive potassium with it, per kilogram body weight over 24 hours before a surgical procedure. And this is the ratio of the slow to the fast twitch response to electrical stimulation of the muscle. So the higher the value, the fewer or the less fast twitch fiber recruitment is going on. And you can see here that the undernourished were like that previous picture. They had an over recruitment of slow twitch relative to the fast twitch fibers. But 24 hours of glucose and potassium normalized the situation. And they were still undernourished, and their muscles were still diminished in mass. So this is a functional effect, not a muscle mass effect. And is quite an interesting observation. So some of the changes that you get with undernutrition are of course due to a change in muscle mass, but many of them are functional effects due to electrolyte alterations or to other recruitment-related changes which are independent of any change in muscle mass. The other thing about the sort of situations that you're interested in clinically is that many of them will have an effect on insulin resistance, especially the longer procedures and the open surgical procedures. Stress and trauma of any sort will increase insulin resistance. The adrenal medulla, and this is the sympathetic nervous system and adrenal medulla, was one of the bases of the research that I did with Carlo a long time ago. We've continued to be interested in it and continued to measure catecholamines. But some of the other metabolic responses to surgery and trauma, fatty acids and cytokines, could also mediate this effect. The magnitude of this postoperative insulin resistance is really quite striking. This is ongoing research that one of Dilip Lobo and my research fellows, a surgeon called Neela Tiwari, is doing at the moment. And these are the first 10 patients in a study that's ongoing. This is a week before surgery, that's the beginning and end of surgery, and that's 24 hours after surgery. And this is an acute phase protein response, CRP. And you can see that there is clearly a substantial CRP response. What I'm interested in is this, which is the insulin sensitivity response. The patients are amazing to actually agree to have this done to them, but Dr. Tiwari is also amazing to be able to do it, in that we've done a glucose clamp on them a week before surgery, and then she does another glucose clamp 24 hours after surgery. This one is in my laboratory, that one is not. That is on the high dependency unit, because there's no way I'm having Dilip's patients in my unit 24 hours after surgery. But what you can see here is a 50% reduction in insulin sensitivity 24 hours after it is an open upper GI surgical, it's an open GI procedure. We are waiting the recruitment of the next, complete recruitment of the cohort, because this is a pre-op carbohydrate supplementation study in half the patients and not in the other half, and so to see if there's any impact on insulin sensitivity and cytokine responses. So what we've been doing in the last few years with Dilip and with Sharif Awad and other colleagues is to look at the impact of some of the procedures that you inflict upon patients, short-term starvation, ERAS carbohydrate protocols, and so on indices of muscle function and insulin sensitivity. And the first ones of these have been done in healthy volunteers so that we can look at mechanisms, and then the later ones, the final one I think that I have today is actually from one of the clinical studies. And so what we've been looking at is some of these biochemical mechanisms that underlie the development of insulin resistance during starvation, and whether or not there are any mitochondrial changes that have occurred at the same time. The other thing that we've been doing in these studies is to use one of the facilities that Nottingham is internationally well known for, and that we, in terms of clinical investigators, are extremely lucky to have. You've all seen one of these things. It's an MR, it's a 3T MR scanner. What you probably don't all have is 5 MR scanners available for human research, and they're not used clinically at all. So we have 2 3Ts, 2 1.5Ts, and a 7T whole body human scanner for research purposes. It's amazing what a Nobel Prize will get you when you go to the head of the university and ask for some resources. And fortunately, our professor of physics, Sir Peter Mansfield, with an American colleague, got the Nobel Prize for medicine about 8 years ago for inventing that thing. So we use it for imaging. There's a cross-section of the abdomen here with the liver, but we also use it for biochemistry. And so what we look at is, and it's MR spectroscopy that we use to measure muscle fat. This is extramuscular and intramuscular fat here, and also measure liver fat. So that's the voxel that we actually measure, do the proton spectroscopy here and look at the liver lipid. This is a normal volunteer. If you had a patient with NAFLD, the peak would be up here somewhere. So we can use MR spectroscopy as well as imaging to do some biochemistry. We can look at glycogen. These are not surgical patients, these are diabetic patients, but overnight fasted, then after meals, and then progressive exercise, effects on liver glycogen. Just to show you, it's not just muscle glycogen that's used in exercise, you use your liver glycogen up as well. But the MR spectroscopy allows you to track that over time without sequential muscle or liver biopsies, which of course the latter would be very difficult to do. And so what Sharif did was to use the MR techniques to look at glycogen content in the liver, and to look at fat content and mitochondrial function as well in healthy volunteers. And these are the liver data. So what we have here is the overnight, well, in fact, the fed state, an overnight fast, 24 hours fast, and then feeding them an oral nutritional supplement. And you can see here liver volume goes down as glycogen is used. Liver glycogen falls and falls further and then is restored by the ONS. And liver lipid content falls and of course doesn't really change with the ONS because apart from anything else, there's no fat in it. So the MR spectroscopy allows you to follow what you would have predicted would happen, but it's nice to see it actually happen. And this is muscle fat, and so this is quite interesting because there is a change. It's not a very big change here, but there is a change in muscle fat content as a consequence of starving. It seems to go up, which is really quite interesting, but we haven't yet explained that in any great detail. But spectroscopy does allow you to plot these changes without having to do multiple biopsies and so on. So what are the potential mechanisms of this preoperative feeding, of the beneficial effects of this preoperative feeding? Fasting increases fat oxidation, reduces glucose oxidation, and reduces insulin sensitivity, as I've shown you already. Surgery produces insulin resistance. So are the molecular changes in surgery similar to those seen in fasting? And what is the effect of this ONS-type feeding? So what Sharif did in one of the studies was to actually look at patients in relation to pre-op feeding the night before, and then he rang them up at 4 o'clock in the morning and reminded them to take the second dose of ONS, which is certainly a very impressive protocol to adhere to, and then was involved in the surgery when they came in at 7 o'clock for surgery. It's a modest carbohydrate load in total, only 150 grams with the other things that are in there. We took biopsies from liver at surgery and muscle, and there was no clear change in mitochondrial function. There was no effect on muscle glycogen, which with that much of a load and no surgical exercise, I would have expected no change in muscle glycogen. But liver glycogen was higher in the patients who had received the ONS. The PDK4 expression in muscle was lower in the ONS-treated patients. And of course, PDK4 is the thing which then turns off your ability to utilize carbohydrate in Krebs cycle. And so you would have sustained, so this is placebo and that's ONS there. So that is consistent with the ability to maintain utilization of carbohydrate in skeletal muscle as a consequence of the ONS treatment. So what about possible preoperative strategies? Clearly, preoperative carbohydrate feeding is of benefit. It's been shown. The mechanisms are not fully explained yet, but they're being investigated further. Physical fitness training is something I think, and Henrik touched on this yesterday, needs to be looked at in more detail. Now, clearly, if it's an emergency procedure, you can't put your patients on a training program for 3 weeks before you operate on them. But if you've got elective procedures that are being planned sometime in advance, and you have patients who are able to at least maintain physical activity and preferably increase it in order to enhance muscle function, then their ability then to be mobilized after surgery and to be active after surgery is going to be more substantial anyway. So actually looking to see what the effect of training programs on outcomes of elective procedures, I think physiologically is well worth pursuing. But what about other aspects of diet? Now actually I do know that Dilip, one of Dilip's fellows, has been looking at this already, but I purposely have not put those data on because I don't want to steal anybody's thunder. I'll show you what we've been doing in healthy volunteers with carnitine. So remember back to that biochemistry slide where carnitine was involved in fatty acids, but its entry into mitochondria, but it's also involved in mopping up excessive amounts of acetyl-CoA that you might generate from glycolysis into Krebs cycle or from fatty acids. So carnitine potentially has effects on both carbohydrate and fat. Although I must admit, when we planned this study, we thought it was only going to improve fat utilization. What we did was we got some healthy volunteers to undertake carnitine supplementation for 6 months, or a control, and this was done double-blind and randomized. And we actually used the same arguments that we had used for creatine supplementation enhancement some years earlier, because the carnitine transporter seems to be sodium linked and it's probably insulin sensitive. That was our argument anyway. So we had either carbohydrate supplementation or carnitine plus carbohydrate for 6 months in these young men. And of course we took muscle biopsies because we do that sort of thing, but we also did some exercise tests and some analysis on the muscle biopsies from exercise. What we have here is total carnitine in muscle in the 2 groups. Starts to separate at 12 weeks, and at 24 weeks there is about 20% more carnitine in the carnitine supplemented muscle than in the other. The relationship, the metabolic consequence of that is that at lower intensity exercise, so this is exercise along here at 50% of VO2 max and then 80% of VO2 max at 0, 12, 24 weeks, 0, 12, 24. And what you can see here is that at 50% of VO2 max, there is actually a halving of glycogen use during exercise with carnitine supplementation. So there's much more fat use going on. But then when we actually get to the high intensity exercise, there is less anaerobic metabolism going on, and there is actually a greater activation of the pyruvate dehydrogenase complex. So the efficiency of carbohydrate oxidation and utilization, less anaerobic, more aerobic, is increased at high intensity exercise, whereas actually carbohydrate is being spared and fat is being used more effectively at low intensity exercise. We had predicted that would happen. We did not expect this to happen at all, but actually it did. Now, what's really interesting is that the sports science fraternity heard about this before it got published, and certainly one British Olympic athlete has been taking carnitine supplementation for a year before the last Olympics and did quite well. And that's as much as I can say, because that individual is actually sponsored by a carbohydrate supplementation company, and it wasn't their carbohydrate we had added to the carnitine, but that doesn't matter. So carnitine reduces carbohydrate use during low intensity exercise and increases high intensity performance in healthy people. What does it do to patients, the sort of patients that you might be dealing with? We don't know, but it's certainly worth thinking about for the future. So postoperative insulin resistance is associated with poorer clinical outcomes. We know that in many circumstances, not just in surgical procedures, but in terms of diabetic patients, hypertension, heart disease, various other patients. In your setting, pre-op feeding can reduce this effect, and it may be partly, well, I suspect it's more than maybe, I think it's likely to be, at least in part, due to the molecular responses of skeletal muscle to the feeding. But I'm a scientist, and we live on the next grant and the future papers and the future fellows who do all the work, and so clearly further work is needed to determine the detailed mechanisms of the benefit, but also to assess whether physical training and dietary supplementation can actually give you even further benefit in relation to the outcome of your procedures with these patients. And that should be the end. Yes, it is. Okay. So thank you very much, and I'm actually happy to take questions if anybody is interested in asking any, and thank you for your attention.